Well, it's great to be here. Thanks for the intro, Andy, and thanks for inviting me. And thanks for such a really good turnout on a very cold Tuesday morning from our computers. And I just want to start off by saying, yes, it's not the most cheeriest subject for 11 o'clock in the morning, but thank you so much for being here. And this is, although this is my presentation, it's clearly collaborative work. This is work absolutely I've carried out with Andy. Andy, I can't believe it's been 6 years and I haven't seen you really for a year. And it's absolutely in collaboration with people living with dementia, with carers, with Dementia UK, with Alzheimer's Society, with a large number of NHS trusts and nurses, healthcare assistants, clinicians, allied health professionals. It's a very collaborative piece of work. So I'm going to tell you, this is based on the book, but it's one slice through the book that I think is quite interesting, is something that really struck Andy and I really from day one, is the rules of the ward. So just to give you a bit of background, is really over the last 10 years, we've seen a really rapid increase in the number of people living with dementia in our acute wards, in our hospitals. And I think particularly, yes, we know that around 25% of people with an acute condition in our hospitals are also living with dementia, but we think that's an awful lot higher. It could be 50%, but actually lots of wards are saying it's even higher than that. It's more like 70%. And that really reflected the level in the wards that we were observing, Andy and I. They're also a group who are really high users of emergency services, typically for really urgent care. And that's also, quite a difference from other groups. They're also a group that tend to be at an earlier stage in their dementia trajectory. So they tend to be either early, mid-stage dementia, often undiagnosed. And this is also a site where there's high diagnosis rates. And this unplanned admission is typically for a potentially preventable condition, often pneumonia, UTIs, but a significant one is fractures. So there are a massive population in our hospitals, but at the same time, they're a group at really high risk of poor outcomes. Of this group, they really are at high risk of dying during admission. Almost a quarter die during their admission, and they're at twice as risk of dying compared to patients admitted for the same sort of admitting condition. So it's a really, really high risk in comparison. And that was really one of our starting positions, is why is this the case? So on one level, and I think hospital cultures tell us this, is that yes, is this really a problem? Dementia is, by its very nature, a progressive and life-limiting condition. So on the surface, these high rates where people with dementia are admitted for, a very serious acute condition, that combination, in some ways, those high rates seem unremarkable. And within the acute setting, they're quite often viewed as natural, unremarkable, inevitable, to be expected. Oh, they deteriorated so rapidly. Oh, it's to be expected. Oh, what a shame. So it's very much attributed to the person's dementia. And in lots of ways that makes sense, because yes, it's progressive and life-limiting, but also we know dementia is the leading cause of death in England and Wales. But what Andy and I would like to suggest, and what we suggest in our book really, is what if the cultures of care, these low expectations for recovery, the ways in which care is organised and delivered at the bedside, what if that actually has some significance and it has some impacts on these high rates of mortality for this group? What if hospital care itself contributes? And we'll come back to this issue of culture later, because this question of culture is really critical. That's just one aspect in which we see cultures of understandings of dementia within the acute setting. And we know from a large number of reports, inquiries and press stories such as this, that culture is critical and really shapes care and how people with dementia are viewed within the acute setting. And we know as well that there are lots of iatrogenic impacts of the hospital admission itself. So that hospitalisation itself is really bad for people living with dementia. It negatively impacts on their dementia, causing further functional decline during admission and high rates of institutionalisation. So one of our guiding focus was really on looking at, what is culture here? How does it shape bedside care? How does bedside care impact on people living with dementia and potentially having an impact on these poor outcomes? So given these high rates, yes, hospitals and the NHS have responded to it. So there has been a response, but we would say that these responses to care quality and poor outcomes has definitely been a very kind of reactive approach to seeing dementia as a problem. So we've had new types of wards emerge to classify people by ability, by condition, and by age. We've had outsourcing of skills, so rather than skill up the workforce, it's been identifying small specialist support schemes by identifying dementia at the bedside, so that busy staff can see people with that condition. But we've seen very little that really looks at how we might shape and support ward cultures to care for this large population in our wards. And what we've also seen as well in our work is it's a highly resistant setting. We've written about that quite a lot in the book, but it's a very resistant setting, a very old setting of care that really resists interventions that are thrown into it. And these interventions have typically tended to focus on work as imagined rather than work that actually is carried out in wards. So in response, Andy and I have got a couple of grants looking at key aspects of care. We really tried to focus on aspects of care that were seen as really problematic for people with dementia, carers and staff. The first was looking at refusal and resistance of care as a phenomena that presented in wards and staff, and everybody found very difficult. And then also looking at continence practices, which is a really key in personhood and identity, if you can, but also for outcomes. Andy and I have carried out a year of field work being in hospital wards. We're absolutely committed to detailed ethnographic field work in ordinary hospitals across England and Wales. We've been in 16 wards across 8 hospitals in England and Wales. We've got probably over 1 million words of field notes by now, lots of case studies, lots of interviews with staff, very much ethnographic interviews we've focused on as people are doing everyday work, as people are in hospital wards, talking to them about life there, work as done. But you can ask us more about that later. We've got a number of publications we focused on, various aspects of our research. But today we're going to talk to you from kind of one slice through wandering the wards, our ethnography. It's totally open access and free to download, so please feel free to download on Kindle or Google Books, or through the publisher. So one of the things I think that we found really important is that the ward is a small society. And we've really gone back to some of those very early ward hospital ethnographies to really think about the current wards, the contemporary ward. And there've been a number of ways in which wards have been viewed. They've often been seen as something that's quite separate from everyday life, as tight little islands of vivid and capturing activity within these wider institutions. And we too found that people living with dementia were in some ways little islands set aside from and set apart from the wider world of these wards. They were very isolated within these settings. But also hospitals are seen as reflecting the wider society. They've been described as a small society and society in miniature. And we also found that dementia as a condition was understood by these non-experts within these wards as really reflecting that wider social understandings of dementia, really poor understandings, lots of fear, lots of stigma, lots of expectations of people not being able to communicate, to being really at quite an advanced stage of dementia. So lots of expectations of dementia as having a particular way in which you presented in the person. And we went back to the classics. After doing our analysis, it was really useful to go back to Stanton and Schwartz, Cordill, Kosa, and the classics, to really think about how our ethnographic work, our take on the hospital ward, how that actually reflected in terms of that kind of historical perspective of hospital ethnographies. And we found lots of continuities. And I think that's something that really surprised us initially, was how much continuity we found within these old classic ethnographies from the 50s and 60s with the contemporary ward. And today we're going to talk about the rules of the ward, because that for me seemed really central in terms of understanding the place of people living with dementia and the limits of ward life, and really shaping cultures within these ward settings. And of course, all patients are expected to learn the rules of these wards. And I think if you go into any institution, you have that sense of, what are the rules here? How do I navigate this? How do I fit in? How do I fit into this this new institutional life? And we found this very powerfully within these wards, that yes, everybody had to learn and pick up the rules here, but for people living with dementia, these were more pronounced. There was a very stronger focus on what the rules are here for that particular group. And we found actually people were living with dementia were often very explicit about asking, what are the rules here? And we found that too. We found every ward we went into, even if we'd been into 10 wards already, we still found that sense of, what are the rules here? Now we're entering through those double doors. What are we allowed to do? Where are we allowed to be? What are we allowed to say? How is care delivered here? And of course, there are rules for everybody. There are rules for us as researchers. There are rules for nurses, and there are rules for patients. And we're going to focus on what are the rules for people living with dementia. Because as I said, yes, absolutely, these rules apply to all, but we found that really explicit reinforcement and emphasis continually for people living with dementia within them. There was a very limited and narrow set of responses that were viewed as acceptable for this patient population, and there appeared to be little flexibility for this group. And this goes back to really, we think about 1950s, 1960s classic ethnographies when we talk about permissions and privileges. Who is allowed to do what? And this hit us on day one. So this is me, a small excerpt of data from my day one in the first ward I went into all those years ago. And it struck me very powerfully. We're not going to go through much data today. The book is full of data and full of detailed descriptions of people, case studies, things that we observed. But I think this sums up really that kind of first day where you start to see what's going on here. And yes, I'm collecting, I'm there with my notebook in the hall, in the corridor, and a young man walks past in his underpants. He saunters along. However, Kathleen, just getting out of bed is seen as problematic. Where are you off to? I thought you were going to escape. And she's just walking across to the bathroom opposite her bay. So that sense of who has privileges, who has permissions to do what, really struck me on that first day. So there are so many rules for people living with dementia and for staff within this setting, but I'm just going to pick a few for today that we thought were really, really powerfully present. You must understand, you are in hospital. This was a phrase that we heard repeated by everybody, every member of staff in every ward that we went into. A rigid, highly repetitive repertoire of tactics, performative work at the bedside. So really narrow range of tactics and tasks, but a real reliance on a very limited range of stock phrases, simplified language, slowly enunciated in that special institutional tone of voice. This was really directed at every person living with dementia that we observed in our wards. Really locating and reorientating the individual within the institution, but also repetition. So the simplified instructions: you're in hospital, sit in the chair, sit down, stay, stop, don't, would also be repeated. There was never a move into any further discussions, but it was very narrow language. As well as the reorientation to the institution, it was also reorienting people to what had happened to them. You've broken your hip, you've had a fall, you're ill, you're in hospital, was very much kind of phrases that were repeated. You must not wonder. So, of course, for staff and for institutions, the thought of and the risk of people living with dementia falling or having a fall or absconding from the ward was a really, really, yes, it was a very real and present risk, but it became a really deep anxiety you could really feel within all these wards, not just of someone falling, but of actually leaving the bedside. So the fear of falling really became focused on instructions to stay in bed or stay at the bedside. So these instructions contained a really powerful sense of urgency. Underlying anxiety of staff was really, really visible, and repeated warnings to people about the potential risks and imminent danger if they started to walk or fail to modify their behaviour within the wards. So there was a really powerful rule: you must not wander, but you must stay at the bedside. Rule 3, you must communicate your needs in institutionally recognised way. Now, this was one of two ways that were institutionally recognised forms of communication. One was to actually verbally communicate, to tell staff of your need. The other was using the personal alarm or buzzer at the bedside. However, for people living with dementia, obviously, communication when they have an additional acute condition could be highly challenging, could be really, really difficult for people. But that these more embodied ways of communicating or trying to communicate to staff was really not recognised in the context of a busy ward, or staff felt unable to recognise and respond to those forms of communication. So for lots of people living with dementia, looking uncomfortable, distressed, potentially defensive, repetitive body movements, looking silent and withdrawn as well, this was really forms of communication that staff just were unable to recognise or respond to. And instead, it could often be seen as resistance to care, as being disruptive or inappropriate, which of course, if these needs are not responded to, could actually escalate. People could get more and more distressed. But rather than seeing that as a form of communication, it could often be seen as someone being disruptive or aggressive. Care needs must fit the timetable. Now, this is a rule for people living with dementia, but also a rule for ward staff. So this goes with that kind of a very fast-paced environment where timetables really dominate the delivery of bedside care. So staff instructions to people living with dementia contained a really powerful sense that of their own anxiety and fear of falling behind. And there was always a point in the day where the timetables fell behind, but that was something that staff could not, there was deep anxiety about that. So this could translate to everyday care at the bedside into a focus on care must happen now, it must happen in particular ways to this person, and a real sense that the institution demands this. So appeals to allow staff to continue work would lead to them talking to the person with dementia that, you know, we have to, there's no choice for anybody here. We have to change you. We have to do this care. We have to do this now. So real emphasis on everybody's status as being at the demands of the institution. This could also lead to people living with dementia seen as being a disturbance, a group who, even though they might be the main population in a ward, really seen as disturbing and interrupting the timetables, and so in some ways not belonging, which really goes to the heart of our looking at culture and how that shapes care, but also understandings of dementia, that sense that actually people with dementia really could quickly become seen as a source of disruption who didn't belong. Rule 5, you must really follow ward etiquette and discipline, particularly cleanliness and bodily discipline. Now, for other people, such as the young man walking along the ward in his underpants, you know, he was allowed to be semi-naked in that setting. He was allowed to do what he wanted. He was allowed to leave the ward. However, for people living with dementia, this was a very, very narrow and highly policed focus on bodily etiquette and discipline and cleanliness. So it became not just whether someone could eat a meal, maybe they would eat it independently but be a bit messy. That was not allowed within the wards. That could be really, really disruptive and really difficult for ward staff to manage. So actually that it would be a lot of asserting control over how people would eat. So it would lead to more kind of feeding of people who could manage to eat, but would be perhaps a little bit messy. But staff would reassert control and really focus on the neat and tidy. The neat and tidy body, the neat and tidy wards was really a powerful anxiety for ward staff to maintain. I've got a little quote here. I'm not sure whether we've got time. We're not doing too badly. So I think here is quite a good example of this sense of the food's arrived, but it's cold. The patient living with dementia is very clear he doesn't want to eat it. He's very clear it's cold. However, the ward team really expects him to eat it. And this expectation of eating it, this saying is cold, rather than actually seeing that as a reasonable response to a hospital meal, is seen as something that actually becomes an issue of questioning the person, questioning their capacity, starting to, you know, and here the doctor starts to begin capacity assessment, asking him where he is, asking him to orientate him to the setting. But it becomes real focus on the importance of eating and eating at particular times. and how this impacts on how staff start to view the individual. So why are these understandings of the rules important? Well, as I think we saw in that quote, it starts to give us some sense of understandings of recognition and understandings of dementia within these settings. It shows us about how the culture is shaped in this ward and shapes both how care is delivered at the bedside, understandings of dementia. So the sense of this kind of reinforcement of the rules really shows us that non-expert staff within these hospital wards really see dementia as a cognitive deficit that requires continual orientation. Verbal and compulsive repetition will somehow remind people of how to behave here and the norms of the institution, that people can grasp this and must grasp this understandings of what's allowed here. A person living with dementia who emphasised their wishes, rejected the timetable, or wanted care outside of the timetable order, for example, support to go to the bathroom, there's kind of an urgent need to go to the bathroom, are really seen as highly problematic for staff.
Thanks, buddy.
And could become a focus of concern. So rather than seeing that as a really reasonable response, that need for urgent care, it could be seen as a feature of the person's dementia, an inability to understand the rules here. But it could also be seen as willful rejection of the rules of the ward. And these two things coexisted for the same person at the same time, in the sense that actually, yes, it was their dementia, but they were also being willful and rejecting how we do things here. And this really reinforced ward culture's understandings of dementia, understandings of the person, that could really start to escalate and see the person as other and who didn't belong here. And of course, I think you could probably see from all of these rules that these were also a lot of rules for staff, and their care work was really highly restricted in this setting. And we've got a chapter on this in the book where we really look at how, when staff are really doing that really incredible, amazing work to support people living with dementia, how actually that became really problematic for other staff. It became work that was singled out and was stopped and was seen as something that must be restricted. So we found that conversations between staff and people living with dementia was highly restricted, was not valued, and was seen as not work here. This is not what we do here. And I think that reflects, really long-standing institutional cultures where, the boundary between staff and patients was really, really powerfully maintained. Instead, what we found was that sort of interactional work supporting people living with dementia was work that could only be typically prescribed or carried out by specialist workers and services, for example, dementia care workers, meaningful activity coordinators. These were absolutely highly skilled staff, and we observed a lot of them working in these wards, but there tended to be a very tiny group covering an entire acute hospital. So they were really stretched thin, but it was really seen as their work. It was outsourced, or it was outsourced to one-to-one carers who were there to contain people at the bedside so that staff could get on with the busy work of the ward. So really a sense that staff had very limited ways in which they felt able to deliver the care they clearly wanted to deliver, the high quality care at the bedside. That was really, really limited for them. And instead what we found was a real tightening of the timetables of tasks. I talked earlier about concerns of staff about the fear of falling behind with timetable work. And that was true in every single shift. The fear of falling behind, both the internal timetables of the ward, but also meeting the external pressures, being ready for the medical teams around, being ready for lunches or meals to arrive, and having certain things done by certain times. And staff employed a number of techniques to keep to this timetables and stop them from falling behind. I mean, falling behind was absolutely inevitable, but there was a sense of increasing pace. Care work at the bedside became really limited and even narrower, so a reduction of care to really rigid and highly repetitive talk at the bedside. A reliance even more on stock phrases and simplified language we've seen already. But there was a point during almost every shift where this actually created more distress and disturbance. What Stanton and Schwartz called the collective disturbance. This further tightening really led to further containment and restrictive practices at the bedside. This led to more distress in the patients living with dementia, more distress and anxiety in staff, and so you get these this looping effect that I'll talk about in a minute. There's just one other example. I'm not going to stay too long on this, but this is an example of a real sense of urgency and anxiety in this bay. This is a bay with I think 4 or 5, probably 4 people living with dementia. They're all sitting in their chairs and there are chair alarms attached to their chairs. This is a safety measure to the alarm will go off if the person living with dementia starts to move or get up from the chair. The problem was these are highly sensitive instruments, so you just have to wiggle in a seat and they go off. So here is a group of patients. They're moving slightly in their chairs, the chair alarms are going off, and they're trying to eat their lunch. And the focus for staff becomes the high anxiety of actually managing the chair alarms. The chair alarms become the focus, and it's don't wriggle in your seat. The nurse doesn't feel she can turn it off, but she resets the alarm, and this pattern continues. So this is how these things lead to distress in everybody. So this kind of sense of escalation through the shift. And what we get with the sense of enforcement of these rules and cultures of containment is absolutely, we get high levels of restrictive practices, restraint, containment and restraint. As we've seen earlier, the verbal commands, but there were also many indirect approaches to contain people at the bedside and maintain them, so we enforce the rules of the ward. So as well as verbal commands, we have the removal of walking aids, the raising of bed rails and tucking in sheets. These are not to support someone from and prevent them from falling out of the bed, but to keep them contained within. And there's high use of clinical technologies, particularly continence technologies and pads. Andy and I are working on a report looking at pad use in hospitals, which continence pads, which we think is really, really significant. Highly secure, tightly secured medical equipment, safety technologies that we've seen with the chair alarms, but also staff care interventions such as one-to-one specialing and enhanced care, repurposed as seclusion and containment. We've really found some really powerful interactions between the way care is organised and delivered, this tightening of the timetables, this pace of care, this restriction to limit and restriction and tightening of tasks at the bedside, to high stress and anxiety in staff, but also distress in people living with dementia. These ward cultures really amplified both the behavioural responses from patients in rejecting care and also amplified the restrictive care practices enrolled by staff in response to them. So as Menzies' list pointed out in 1959, it seems very normal behaviour in a hospital setting is likely to include a good deal of expression of distress and protest, a normal reaction to an abnormal setting. So that you get this really the tightening of the timetables, this anxiety of staff, really amplifying the distress in patients. And this could really lead to these collective disturbances during the shift. And I'm close to the end now, Andy, so don't worry. And what we found is these organisational priorities, this culture, institutional cultures created looping. And of course, Goffman has identified institutional cultures of looping within his classic works. And we really saw these dynamic interactions locally, daily during shifts within these wards. Many of the routines and procedures reflecting the organisational priorities of the ward, the tightening of the timetables, the containment of the bedside, really contributed significantly to the patterns of behaviour in this patient population that these organisational interactions were trying to contain and stop and maintain. So it was a really tightly bound system, really creating another. So here's just an example of how we see this institutional looping, this kind of fast-paced delivery, really leading to patient resistance to this timetable care. Staff seeing this as disrupting the timetables, inappropriate, transgressive. And then this starts to feed into understandings of dementia and seeing that as something that requires particular types of management, doesn't belong here. And then there's further tightening of the timetables. Talk becomes more rigid, repetitive, and that's when we get more restraint at the bedside, which of course generates further distress in the person and in ward staff. At the same time, we also see this looping in terms of how it shapes understandings of dementia. So if we see all of staff within these wards as being non-experts, they're experts in their area of clinical expertise, but not in dementia. So this looping also informs their understandings of dementia. And they start to see rapid deterioration as normal, and distress becomes viewed as agitation, aggression, to be expected in the person living with dementia. So it's really dynamic interactions between the organisational interventions and timetables and techniques and containment, and actually both the status of the person living with dementia, but also understandings of dementia as a condition, which can also have impacts on care in terms of features of dementia being seen as features of the expressions being seen as the person's dementia, when actually it might be a feature of their underlying acute condition, or a feature of sepsis, or something more serious, and that becomes overshadowed by the dementia diagnosis. And I think I'm going to end there, Andy. I think that's just to say that I think really that sense that really these chronic patterns of behaviour in the institution, in staff, in people with dementia, really became this kind of collective disturbance, which we saw pretty much during every shift.
Right, so in that case, we should open it up to the crowd for the Q&A. Now, this is my first time doing this, so I'm going to look like a complete amateur as we go, but I can see we've already had one question during the talk from Graham. Can you see that, Katie, or do you want me to read it out for you?
Can you read it out? That'd be good.
Okay. This is really fascinating, thank you. It strikes me from some of the findings that staff could be very selective, perhaps instrumentally so, about when they considered patients with dementia to have agency and when they did not. For example, someone willfully disrupting the ward because they wanted to go to the toilet, but someone else lacking capacity or agency to make their own decisions about whether to eat a cold roast dinner. Do you have a sense of how deliberate, strategic this was? Were staff being consciously selective in this attribution of agency? Or is this too much of a product of the rules and routines of the ward? And apologies to Graham, who would have probably said that a lot more charismatically than I just did. So
thanks for that one. Yeah, I mean, it's really interesting and tricky to untangle that, but I'd say there is absolutely an awful lot going on. My sense is so much of it is shaped by the powerful cultures that over time, this is what we do here, this is how we respond to people. So I wouldn't like to say that individual staff are making decisions about, actually, I'm not giving that person agency, because I actually believe everybody within these wards really wants to give the high quality care that they were trained to do, and that's what they want to do. You know, Andy and I really didn't see anything other than, I think everything we're showing is very much normal care within these wards. Nothing within the book is extreme examples. They're all something we saw in every ward every day. So we see this very much as culture shaping. This is how we do it here. This is how we talk to people here. This is our expectations of how you are within this setting. So, but I think that looping impact on this is how dementia is was very powerfully felt, that in these settings, dementia became a very narrow classification. It became something that was viewed as people didn't have agency. They had poor understanding, hence that, you know, you are in hospital, that institutional talk and repetition that would somehow, repetition was seen as something that would work, but actually just escalated everybody's anxiety. And I think there's something about the pace of work in hospital wards that means nobody has a sense to step back and go, actually, what are we doing? Didn't we just see how if we all gather around a person going, you're in hospital, that might not be nice for anybody. So, but it was something that we saw again and again. And I think that's, for us, the kind of power of actually the institution and the worlds of these wards is so rigid and repetitive. And I think that's also why quite often interventions fail in this setting, because they just bounce off this very powerful culture. Sorry, that was very long-winded.
No, I think I just add to it before I go to the other questions, that you're in the hospital bit. I think because of the way the hospitals work, people don't realise that they're the 8th person to come in the room and say you're in the hospital and then leave. So you get repeated, someone will be with you in a minute, then someone else comes in and you're in the hospital. So yeah, it's... Anyway, moving on. Our next question's from Malcolm. I feel like a TV presenter in the 80s doing the lecture. Given the lack of understanding among healthcare staff, how is this being addressed in training and education, including CPD?
Oh yeah, good one. Yeah, and I think, as I said, you know, so many interventions just bounce off these cultures. So you've got to be really, really careful. I think that's one of the reasons why we started with the importance of ethnography, to start unpacking and understanding cultures of care, rather than just going in with interventions and going, okay, let's try and change care. Just like, you know, the labeling of people at the bedside as having dementia or not. You know, if we'll just do it, you know, a dementia friends event, we'll label the ward dementia friendly. These are just little plasters stuck on these wards that really don't really respond to work as done in these wards, culture as understood in these wards. And that's what we've got to see, is trying to see those kind of little ways in that we can start to support ward staff to see their work and what it's producing and how they might want to do it better. I'm not sure that's answering the question. Andy, did I answer it?
Yeah, I think that's it. And we've got a similar question from Fawn asking, do we have any... I'm going to ask a few questions together because there's some common themes sort of coming up. So Fawn's asked, do we have any plans or ideas for how we can change the way staff think about or care for people living with dementia in hospital? And Natalie's asked if we went back to the staff on any of these wards to ask for the ways they responded to it. I think that's kind of linked in with that.
Yeah, and that was really important to us, that we didn't just go in and do ethnography and just disappear with our findings. So something we've done during the ethnography, we were really clear to share early data that we'd written up anonymously to share with staff, to share this is what we're looking at. We're looking at these detailed interactions at the bedside and seeing how they made sense of that. Was sparked some really interesting discussions. People were really liked being seen, and they liked the work that they were doing to be seen. We've been working, then taking off our findings from those wards back to people in a sensitive way, but I think it really helped them to start to see their work and what they were doing, the great things they were doing, but also the challenges and how those sorts of things like that you can't necessarily see if you're in a shift, but as an outsider you can. That sense of the timetables taking over, that fear, that pressure, that, you know, when everything just goes wrong at a certain time in the afternoon, there's collective disturbance, helping them to see those patterns. I think it was really important for them.
Yeah, and with the timetables thing, it's going to be that weird thing where the answers and the questions start to overlap each other. But we've had a couple of questions about, we've got one from Petra saying, you mentioned Menzies Leaf and the idea of systems as a defence against anxiety, and what factors do you think drive anxiety on the wards? And further down, do you have any suggestions from your observations on how to de-escalate the anxiety within the institutional cycle?
Yeah, I mean, that's all great. I mean, I absolutely love Menzies' list. That was obviously taking a very psychoanalytic approach, but I think it's really beautiful. And when we read that, it was like, you know, it's 1950s, early 60s. It's actually like us going back in, being in the wards now. It felt so present to me. And I think that's the enduring power of hospital wards. There's so much change and transformation in medicine. There's so much technology and being introduced, yet the work of the bedside, the hospital ward, has really remained very, very stable. I think that's really fascinating to us, is how that stability. In terms of anxiety, I think, again, it's back to this sense of hospitals, when they see a problem, they throw more things at it. So there are more interventions, more tasks to be done, tasks to be recorded. So staff at the bedside have very tightly timetabled work, but they also have even more to cram into this in terms of recording and reporting. So I think that adds to that sense of anxiety. So all the interventions that tend to be, you know, we'll you know, risk manage and support people, actually just add to the workload and the sense of, for staff, of not being seen or understood. You know, if you go to a handover session, there's always going to be something on a new policy or a new procedure, and there's a collective sigh that this is the institution not understanding them, and not understanding their everyday work, and understanding what happens at the bedside, and understanding their patient population. Rather, it's an institutional response that views them as you know, we have, you know, it goes back to that quote of, you know, we have no choice, we have to change you, we have to do this. You know, a real sense that for staff, they don't really feel they have any agency in this either. Okay. Yes, I think that's. I'm ranting again, Andy. Stop me.
It's fine, it's fine. And it's I've got about 101 questions that I'm trying to work out and who's typed when, because all the timings are. I'll change the bit slightly. So Chris Elsie's asking, in terms of ward culture, were the staff members based in the ward, or is there a lot of changing of staff members, sort of drawing on the flying nurses?
Yeah. We chose our wards particularly so that they were very much average wards, but some of them had very, very stable staff populations. So some that we went into would have staff they'd all been there for 10 years plus. So very, very stable population of staff, whereas others had a far more fluid, far more use of agency staff and that kind of thing. So, which I think absolutely does have an impact on ward culture as well. But it's very interesting to see how quickly agency staff can suddenly take on, this is what we do here, this is how care is done here, this is what they expect me to do. But I do think that it becomes very, very difficult for teams to have a sense of how we might, I think adds to anxiety in the regular staff when they have far more agency or far more dynamic population of colleagues coming through.
Okay, right. I realise we've had you talking for nearly an hour now, so I'm going to be slightly selective with the questions. So
you can answer some of these, Andy.
I've got one on methods coming up, because I think that's important for anyone listening that's wanting to go in and do.
Love a methods one, yes.
And then there's one afterwards that I think will trigger an almighty rant, and if it doesn't, I can do it for you. We'll go with that. So the first one from Rachel. How did you find physically being on the ward? How did you explain your presence and negotiate your own space? Yeah. And what did you do when you were on the wards?
Yeah, that's a great question. And, you know, we've tended to kind of fly over methods in our presentations. We've talked about it a bit more in the book, I think, but it's something that does, I think, thank you, Andy. Ethnography is quite hidden in terms of what we do. So we always made sure that we had a senior nurse supporting us to gain access. We very much went through nursing routes to support us, our entry into the wards. Generally, it's just us and a notebook. Andy has small notebooks. I have big notebooks, so that as I'm writing, people can see what I'm doing. They can see I'm writing. You know, I don't go and hide away in the corridor to write up notes. I do it in view of people. We always started off in the morning, handover shift at 7:30, shadowing staff. So being at the handover meeting, introducing ourselves, saying what we were doing, and really just emphasising that we're very interested in the everyday work nurses are doing. Yes, we're interested in the care of people with dementia, but we want to see, to look at their lives and their working lives. It's very easy to see who's anxious and who's nervous about being observed. And it's very easy to find the first person who's really, you know, bouncy and wants to be observed, and to go with them first. And then over time gain trust that actually it's okay. They can look at my notes. I can read out bits I've written, and people and also I'm asking questions as well as I'm shadowing people. So I'd say by the end of our time, so we spend maybe a couple of months with a team, it would be normal for us to be there and for, you know, us to kind of move around the ward and be part of it. Yeah. Have I missed anything, Andy? You carry on.
No, I think the only difference is there was a slightly gendered element to it, where you had to sort of set yourself into the wards and would go on the tea breaks and meet with the nurses and build up. And then I could just show up anywhere because I was a white middle-aged man in a shirt. So it was kind of presumed I was meant to be there, and nobody ever questioned it. The door's ringing, which is typical. So
carry on. It's your Amazon delivery, Andy.
I knew that was going to happen. Been waiting for a DHL parcel all day and knew it was going to come during this Q&A. So that's so next question before that rings again. How important is the built environment of the wards, and could building wards differently make a difference to the care of people living with dementia?
Yeah, I mean, the built environment is really interesting, and we started to look at that, and we definitely catalogued that data, but we haven't really looked at it in detail. But I think it's interesting that the old-fashioned Nightingale wards are seen as old-fashioned and not fit for purpose, but actually they do really well. The wards where I think I found people live with dementia the most isolated, or the higher use of restrictive practices, particularly thinking about the chair alarms, was the very new builds. These have a lot of space, but they have a lot of bays that are cordoned off. You can't see across a ward. You have to go into a bay to see people. And there you could find groups of people very, very isolated, or just left with chair alarms because staff were in other places. So for me, it's interesting that actually a sense of what's a an appropriate ward setting and how new builds should be really doesn't reflect the needs of their patient population, people with dementia. So for example, we have lots more new builds where there's a focus on single occupancy bays. Now that might be good, and I remember sitting in a meeting with a team who were designing a hospital, and they'd commissioned an entire hospital with only single bays, with single rooms for all patients, and that's because a survey locally had said that's what their population wanted. Well, the population is not going to be in the hospital. The people who responded aren't going to be in the hospital for very long. They wanted that, you know, that private hospital experience. But for people with dementia, that can really, really add to distress, isolation, and also contribute to high rates of delirium. So I think there's a really interesting mismatch between what we think of as the ideal modern hospital and who it's suited for, because it's not suited for its current population.
See, I thought that was going to trigger you on a rant about some of the dementia-friendly hospital builds we did see, because there was some wonderful ideas that you would see, but you'd try and figure them out. So people would, like when we arrived on wards, and I'm sorry for taking over, I'll stop.
No, go for it. I'm with you on this one.
Would show you their dementia-friendly features. So a really common one would be, we've painted the toilet doors yellow so people with dementia know where they are. And you'd be like, is the toilet door yellow at home? Because otherwise it's just a big yellow door. Why would they know? Or there was one brilliant one where they put a light up window on a ceiling with a fake blue sky so that people would know it was daytime, and they're good, so they know to wake up. And then I said, what do you do at night? And they went, as if nobody had considered before that there's now a blue sky for 12 hours when it should be dark outside. Or kind of painting on fake scenes of trees or coffee shops. And I remember one old lady, and they're trying to reassure us that you are in the hospital. And she's going, this isn't a hospital, it's a coffee shop with a bus stop in it. And you're like, yeah, that's what this looks like. It's not a place anymore. It's
yeah, absolutely. And in a sense that people with dementia there's some idealized notion that 1950s is with Bakelite equipment is actually a rosy time that people want to remember or actually has any relevance to them. It's really strange that, you know, music stops with the 1950s in hospital wards. Decor is focused on 1950s, and you're right, the little coffee shop. And lots of the time, these interventions that are, you know, dementia friendly actually remain completely unused. There's a real sense that they must be pristine and preserved, and actually don't use it, don't touch it, don't. Is actually quite a common response to, you know, beautiful rooms that have been designed for the 1950s dementia patient, but are absolutely unused and must remain so.
Right.
Which is also part of that kind of that ward culture.
Okay, I'm realising we're through till 12 o'clock and people are starting to say they need to leave, so it's probably time to wrap it up. So apologies to anyone whose question or comment I've not a chance to read out, and apologies to anyone's comments that I butchered as I did read out. But thank you very much for your time there, Katie. That was brilliant. Thanks for answering all the questions. Thanks for a really interesting...
Thank you so much.